Get started, I'll speak to you today about updates on artificial intelligence in colonoscopy. As many of you are aware, colon cancer is a serious problem throughout the world. Nearly 1 million deaths in 2020 worldwide, over 50,000 deaths in the United States. For this reason, obviously, we perform screening colonoscopy, 11 million performed in the United States on an annual basis. Despite that, colon polyps remain a serious problem, specifically missing of colon polyps, missing adenomas. Any tandem colonoscopy study that's ever been performed has demonstrated a miss rate when it comes to colon adenomas. And so over the last several decades, we've seen AI in healthcare continue to evolve. And specifically, over the last 10 to 15 years, we've really seen a rapid evolution of artificial intelligence in colonoscopy. And we've now reached this age of what I like to call endless AI, where essentially any AI you imagine can be developed. And I'm sorry I couldn't resist the slide at lunch, but just as a fact to that, our biggest database, clinicaltrials.gov, has 86 studies today in AI, in endoscopy, or in gastroenterology services. And so when it comes to the current commercially available AI platforms, we see all these different ones. The two circled there are the ones available in the United States, the GI Genius and the Scout. And these are computer-aided detection type systems, so we call them CAD-E. And then, of course, there's the CAD-X, which is the diagnostic type systems, the quality scores, the CAQ type systems, and then computer vision and natural language processing. And so with CAD-E, most of you have all been very familiar with this. If not, please stop by some of the booths, Medtronic booth that has this, but essentially boundary box around the polyp to help identify polyp when it shows up on the screen. Very high detection accuracy, very high processing time to recognize these. And in the data that we have to date, we've seen significant improvement in ADR. Here you can see a study by Rapici and colleagues, randomized controlled trial that looked at that CAD-E with colonoscopy versus no CAD-E system, and they were able to demonstrate an increase in ADR of 14% with an adenoma per colonoscopy of 46%. And so what about CAD-X? So this is the computer-aided diagnosis to help us differentiate polyps. And it can help identify the neoplastic nature of polyps. And in this video, what you see are these polyps that are being predicted as being neoplastic or non-neoplastic, and with the degree of certainty. And in a study done by Yuki Mori and colleagues, what they were able to demonstrate was a very high sensitivity and specificity of these types of systems with a very high negative predictive value. And the American Society of Gastrointestinal Endoscopy has stated if we can achieve a negative predictive value of greater than 90%, then a resect and discard strategy could be employed, which has the potential to save significant dollars in the United States annually. And so where are we going? So this where we're really headed with AI in colonoscopy is in quality. Here you can see in that top view a scope being withdrawn through the colon, and that medial and superior wall were missed. And here you can see that same segment of colon where the scope is being withdrawn, but instead of missing that surface area, the scope is inserted and paradoxically retroflexed to capture that additional surface area. We all hope we're getting the exam on the bottom, but the reality is many are getting the exam on the top, and there's no way currently to tell the difference. And as such, these quality systems are now being developed to help us measure these things and additionally measure preparation as well as these techniques. And so here's an example of one of these systems, a CAQ system, computer-aided quality improvement, where essentially what's being measured here is the stability of the scope. This is by the EndoAngel group, and essentially there's a speedometer on the scope withdrawal helping to understand the stability of withdrawal. And at the same time, when the view is lost, it prompts the endoscopist, view is lost, please return to the last visualized frame. And when they looked at this system and compared it to controls, what they were able to demonstrate was an improvement in ADR, and this was both in diminutive and larger type polyps. Interestingly enough, with this system, we're all well aware that there is a disparity when it comes to AM and afternoon colonoscopy. The lower ADRs associated with afternoon colonoscopy, but when employing this system, this group was actually able to demonstrate that there was no difference in ADRs whether the cases were performed in the morning or afternoon. We also did some work in this area looking at surface area seen, and essentially we worked with some artificial intelligence computer scientists out of Carnegie Mellon University to understand the different quadrants of the colon that are being seen over a segment to help measure the amount of surface area. And in this case that I'm showing to you here, what you can see is this was a case where there's poor evaluation because the cables broke in the colonoscope. And so as we withdraw the scope over this 5 to 10 centimeter segment, you'll see that the top left and top right are poorly visualized. And as such, those green columns remain, those boxes for those corresponding quadrants remain darker and brighter on the areas where we are seeing. And so what we found was this actually had moderate correlation to expert endoscopists. And ultimately what this can develop is an endoscopic thumbprint or fingerprint, knowing that the patient got a high quality exam. The physician knows that they provided a high quality exam, and the third party payer knows that they paid for a high quality exam. And so this type of work is continuing to be developed, and much of the direction where we're going with colonoscopy and artificial intelligence. Other areas where we're seeing computer-aided quality improvement is in bowel preparation. You know, the Boston Bowel Prep is our most validated prep scoring system, but despite that, we subjectively continue to rate a bowel prep between endoscopies. There's a ton of inter-observer variability on this. And so, you know, CAQ systems have demonstrated a good ability with good accuracy to predict the quality of the bowel preparation with an area under the curve in this study of 0.91 and 100% of the time able to document inadequate bowel preparation. What about the completion of a colonoscopy? This also has been an area of active research in colonoscopy and artificial intelligence. And what we've seen here is excellent performance characteristics when it comes to demonstrating the completion of a colonoscopy by detecting the appendiceal orifice. And this withstands despite the quality of the bowel preparation. And as such, we've seen some of the devices actually develop further in this regard. The latest iteration of the GI Genius platform, if you don't already have this update, you should be getting it later on this year, but essentially provides for the landmarks of having a complete colonoscopy, withdrawal time. But what's really exciting in this is it's actually going to break down how much time was spent in each portion of the colonoscopy exam. In other words, in inspection, in navigation, in instrumentation, and washing. And this will allow us to now have a more scientific approach to ADRs and understand what's associated as we continue to measure this with our optimizing our ADR rates. So really excited to see this come out. It also will be giving the scores of the preparation as the scope is withdrawn. Some other areas of active research are keyboard liberation, right? We're all suffer from distractibility after the procedure and, you know, fatigue during the day to document appropriately in a procedure. Right now, there's a lot of research in generating a SOAP note between a physician and a patient's interactions with the natural language processing models, observing what's happening in the conversations, and then creating a SOAP note from that. Well, similarly, we can do this out of our endoscopy units and having wireless ability to dictate effectively so that this information is delivered to an endowriter that ultimately then translates to a report. You know, see a polyp 5 millimeters hepatic flexure, and suddenly that comes into our report. Now, the future really is really interesting when it comes to what AI is going to do with training. And I think beyond training, this actually has major implications on how we view our entire exam. You know, this was a study done that looked at 685 patients, and they were randomized to complete novices. So GI fellows that had never done a colonoscopy withdrawal before did the withdrawal, and they did it with or without AI, and then they compared it to an expert without AI. And all these patients underwent a tandem procedure with an expert with AI, but essentially what they were able to demonstrate was the performance of the novice with AI met the non-inferiority threshold to that of a expert without AI, which they said at 10%. And so when you start thinking about this, you understand that this is a great way that we can help our next generation of fellows train, but quite possibly this could also turn into, down the road, an AI endoscopist, an AI endoscopist where essentially the endoscopist is going around performing multiple interventions, and it asks the question, do you really need a gastroenterologist to do the withdrawal? If a novice can perform not inferior to an an expert. So, I think these are just some things to think about, but, other individuals to handle the scopes, novices, technicians, nurses are all there, and it has the potential to overcome some of the shortages we're seeing. So with that, I'll pass it over, and I thank you guys for your time.
Thank you. So we will have Torsten Beiner talk to us about AI in ERCP. Again, I want you to understand this is all preliminary data. There is not much happening with AI in ERCP, so we will learn. And again, if you have not got your vegetarian lunch, just lift your hands. It's being distributed around. Thank you. It will be brought to you. Torsten, thank you.
Yeah, thank you very much for this introduction, and also once again, thank you for inviting me again. So I will talk about the role of artificial intelligence in ERCP, so today and tomorrow. So what are the challenges that we have to face in biliopancreatic endoscopy and biliary diseases? So we have to treat biliary stones. We have the challenge to make a differential diagnosis of indeterminate biliary strictures, management of strictures, ductal access, and also decompression of the ducts. We have to treat biliary leaks and also prevent complications. During the last years, the number of publications related to artificial intelligence in ERCP increased a lot, as you can see here in Medline. So what is now the current status of AI in ERCP? So there's no, as far as I know, no system that is commercially available right now, but it's still used in trials. So first of all, AI is used as for interpretation of images, fluoroscopic images, but also colonoscopic images. I think this is the most important part here, and also to distinguish and improve to distinguish malignant and benign lesions. It can be used to assist navigation, also to identify landmarks and to perform the cannulation, and it can also be used to predict complications during ERCP. So in my talk, I would like to focus on two things: treatment of biliary stones, and on the other hand, differential diagnosis of indeterminate biliary strictures. So this is still a big challenge for the biliopancreatic endoscopists to evaluate indeterminate biliary strictures and to guide the appropriate treatment. We have to diagnose these strictures swiftly and accurately. And still up to 25% of all patients that undergo major surgery still turn out to have benign diseases. And so the interpretation of cholangiograms and also of the images from colonoscopy is still challenging, and often also pathological confirmation is needed for the therapeutic plan. We have additional information. Usually we perform MRCP before to have a roadmap for our ERCP, and we get additional clinical data from our patients. So still we have the problem when we perform colonoscopy. We have not very good classifications here. So this is, for example, the Asian Pacific consensus guidelines, how to interpret these images from colonoscopy, mainly focusing on the structure of the stricture and also the vessels that can be seen there. So and this is data from the European Colonoscopy Group showing clearly that even among experts, there is still limited inter-observer agreement here. So obviously the interpretation of these images remains a problem. So still here, tissue is the issue, so we have to go for histopathological confirmation of these strictures. This is one of our trials, randomized controlled trial, comparing single operator colonoscopy, guided biopsies with standard tissue sampling techniques. You can clearly see that it's obviously improving the diagnostic yield here, but still it's close to 70% here, the sensitivity, and this is, of course, not ideal. Here still the visualization is much more accurate here, but yeah, it depends then also if for the further treatment plan, for example, also the surgeons would rely on our visual diagnosis only. So we still have to go for tissue here. Also from this meta-analysis, we see the visual impression has a high sensitivity and specificity in terms of diagnosing the malignancy, but this still highlights the importance of the visual impression. So we have some classifications, of course. We have the Monaco criteria. On the other hand, we have this Robles-Medranda criteria, focusing here on these type of mainly how the stricture look like, papillary projections, ulcerations, and also abnormal vessels. I don't want to go into detail, but still we have here a low inter-observer agreement. So here AI comes into the game. This was the first landmark publication. Artificial intelligence, here convolutional neural network was used to evaluate these pictures for colonoscopy. You can see an accuracy close to 95%, and here this AUC value of 0.99, so it was quite nice. So this was the first publication, and I think there will be more to come, of course. And then this was from Portugal, and here we have data from the United States. And here the network was used to diagnose during real-time colonoscopies, or real videos were used here to make the diagnosis according to diagnosing malignancy. And also heat map technique was used. Again, here it came out that also this type of papillary projections and these neovascularizations are the main features here of malignancy. And finally, it turned out that 30 seconds of a video sequence, unedited video sequence, could be diagnosed here by the system with a very high accuracy. As you can see here, so the accuracy in diagnosing malignancy was here 0.9, and this was significantly superior to forceps biopsies or brush cytology. And importantly here, this was a real-time, real-life environment compared to other techniques that only can evaluate pictures. We have more data here. Other AI systems have been trained. For example, here, so this is also real-time video evaluation, and still this system was able also to outperform here experts and non-experts, of course, in diagnosing malignancy in this indeterminate biliary strictures. So obviously this is a good way to go, but we still have additional data. This is publication from the Baltimore group that comes from DDW last year. So Munker Sharp and his group kindly gave these slides to me. So this was, of course, again, an AI system that was trained on these pictures, but also clinical information was integrated into the evaluation process, and then finally to predict the risk of cancer in the patients. So here you can again see this. Of course, you always need annotated images to train your AI, but then finally you have a lot of additional clinical information. So here in the malignant strictures, you can see males of elder age, and also jaundice patients with weight loss have an increased probability to have a malignant stricture. So this was integrated into the algorithm. And finally, it turned out that only age and the presence or the absence of jaundice was relevant here in this process. And finally, here you can see that here the area under curve of the prediction was 0.88, so quite impressive, with a precision of 0.99 here of this algorithm. So this may be the way to go, not only images, but also to integrate clinical data that we have for the patient. So this is how it looked like. Just say the patient is jaundice or not. The age comes from the system, and then you get the analysis if it's a high risk or a low risk stricture for example, here, this is then the result. So, for the sake of time, should I mention also the biliary stones? Of course, indeterminate stricture was the one part, and the other is treatment of biliary stones. So when we look at the guidelines, these are the European ESG guidelines, how to predict difficult stone extraction of biliary stones. You know, we all know the largest stones, more than 15 millimeters in diameter, and increased number of stones, an unusual shape of the stones, and also anatomical factors of the bile duct can predict a difficult stone extraction. And this is, for example, a system developed by the Chinese group from Wuhan, and they developed this real-time scoring and assistance system to predict difficult stone extraction exactly based on these kind of features, as you can see here. So the system will evaluate here these fluoroscopic images and then predict easy or difficult stone extraction. So, and finally it turned out that the system is working quite well in predicting difficult stone extraction, more in the difficult group, more stone extraction attempts were needed, and also additional therapy like lithotripsy, longer stone extraction time, and a lower rate of single session stone clearance rate, for example. So this may be in the future indicate then an early switch to advanced procedures, cholangioscopy, EHL, and so on. So we still have some challenges for AI, also in cholangioscopy and ERCP, data privacy, that the algorithm is trained in an appropriate way, some regulatory hurdles, and also the ethics behind. So we could discuss hours about that. So this is why I would skip this now and give a short summary. So we will have in the future, and already now, real-time image analysis. The systems will guide our therapy, help in navigating to make the workflow most efficient. Also to provide customized treatment plans for our patients with a decision support system, with also outcome prediction of the ERCP procedures. In the future, maybe also robotic systems that then can be controlled by AI. The adaptive learning system will improve itself, and also simulation training will be provided by AI in the future. Thank you very much for your kind attention.
So there's very little data on EUS, so it's going to be a very quick presentation. Once again, if you don't have your lunch, just lift your hands and it'll be brought to you. So this is AI in EUS. We can talk a little bit about it because at our own unit, we have done some work. There are three things where AI in EUS is being worked on. One, if we all know that compared to other procedures, EUS has a radiology component, and because of that, it could take a longer time to learn. So AI can be used in EUS to shorten your learning curve. And namely, we can identify organs, which is where everybody struggles when they start. The second is making diagnosis in the pancreas. And the pancreas is a difficult organ. Still, we struggle with differentiating autoimmune pancreatitis from chronic pancreatitis and pancreatic cancer and lymphomas, metastatic tumors, neuroendocrine tumors, so many things. So maybe there is a role, particularly when our biopsies are indefinite. And last is quality improvement. I think how good are we when we do the procedures, and can AI help to assess what we do, like what is happening in colonoscopy, so that we can have better metrics and do a better job. So this is a study that again came with partnership from South America and Bucharest, where they took a number of AI normal structures. They divide it into two parts, what you see from the stomach and what you see from the duodenum, and then extracted all the images, trained a model, and after training it, they try to validate it, and this is what they have shown us. So when you look at it from the mediastinum, they trained both the radial EUS scope and the linear EUS scope. And the second category was the gastric window, looking at parts of the pancreas, gallbladder, adrenal glands, kidneys, and the duodenal window, where you will look at head and uncinate process of the pancreas, and the ampulla of Vater, and then some of the vasculatures. And you will see that this graph is all over the place. So if you look at right kidney, obviously it's difficult to see. Gallbladder 93.6 sensitivity. If you look at the celiac trunk, unfortunately, it's very low. One would have thought it would be higher. The left kidney is doing very good. Aortic arch, one would have expected 95%. It did not. So there appears to be a lot of variability between with this technology. And I think it also depends on how you capture the images, what type of an EUS scope you are using. You know, there are three scopes, three scope manufacturers, and there is one more new one. What you capture on one may not be applicable to the other, and so on. So after they did that model, they went back to do a second model. They refined it, and it's called the CNN second model. And what they have told us is, you can see the performance here. You can find the vertebral spine, the liver pretty well, the splenic artery, the gallbladder, and so on very, very well. But there are certain things, again, the right kidney, the aortic arch, the portal vein, a couple of things are not very clear. The trachea, obviously, because there is so much air, it's a little bit fuzzy, and it's got to do whether you're using a balloon and so on. But at least for organ identification, we are at about 95%. Obviously, as you know, for those of us doing EUS, 95% is extremely insufficient, right? We have to be 99.9%. Because I would think many of us who are good are almost at that stage, and EUS AI should keep up with it. We also know that when we diagnose, when we are looking at the pancreas and so on, we've got sampling problems. When the lesion becomes less than 10 millimeter in size, even for an expert endosonographer, things get very difficult. And when you look at tissue diagnosis, cytology sensitivity is only 77%. When you combine it with histology, it's 82%. Relying only on fine needle biopsy for lesions less than 10 millimeters, 50%. This is very good data from Japan. Probably it's a very honest data. And then they wanted to combine it with pancreatic juice sampling and so on, because this is important. The only time we can cure pancreatic cancer is very small. What is very small? Less than 10 millimeters is unlikely to have vascular invasion. But existing technologies are not doing a very good job. We ourselves have shown from UAB many years back that we have chronic pancreatitis in the setting of pancreatic cancer. Our diagnostic sensitivity is very bad. It's about 73%. But when you don't have chronic pancreatitis, and if you have a mass, it's about 90%. So just the presence of chronic pancreatitis can make our performance less effective. How do we overcome? Maybe EUS will have a role. We worked with our colleagues in Romania and developed a program called the Pancreas, and Orlando Health invested some money in this program. We extracted videos, about 1,500 videos that we perform using one scope, which is Pentax, and then we tried to test it out, and then we performed a validation study. So this is how it looks. If it is green, it's a normal pancreas. If it's a solid tumor, it will look quite red, and then when you're looking at a cyst lesion, it will look blue. We have some preliminary data that was submitted to UEGW and ACG, and this is what we have. For pancreatic mass, accuracy is about, let me see, about 98.4% for EUS. 100 of course, because it's who can we compare it with? We can miss, but we think we are the gold standard. Probably a false assumption. And then you realize it's about 98.5% is where AI-EUS is. Not terrible. It's reasonably good. But as I've told you, it has to be 99.9. Otherwise, it's not cutting it. If you look at pancreatic cyst, it's not very good at all. Why? Because a pancreatic cyst is round, and you remember sometimes we ourselves mistake a pancreatic cyst for a vasculature and vice versa. When you talk around and you elongate things, you will find that the AA will pick up one section of the splenic artery, thinking it's a cyst, and then when you keep talking and you put a Doppler and so on, then it gets fuzzy. So for pancreatic cysts more than 15 millimeters that is round close to the transducer, it's about 95% accurate. The smaller the pancreatic cyst, it gets very difficult, and if it's less than 10 millimeter, we did not even check it because the FDA tells us whatever you see, you need to prove it with cytology or sampling. We can't sample cysts less than 10 millimeters because we will give rise to pancreatitis. So starting off, we have a problem here. For pancreatic mass, reasonable. I think if you get to 99.9, we won't miss. But the problem with pancreatic cancer detection is not that we are not seeing the mass. The problem is we may not do a good examination. You have to be able to take the scope to the second portion of the duodenum, find the aorta, find the IVC, find the snake eye appearance of the bile duct and the pancreatic duct, trace it all the way to the tail. When there's a variation in anatomy, we don't do a good exam. AA is going to only pick up what we are going to show. So if we don't go and examine these areas, then we have a problem. So where are we with pancreatic cancer? I think we have the potential to improve the detection rates. We need to work on getting this to 99.9% because 98.4 is not sufficient. We need to increase detection for cysts less than 10 millimeters. It's not enough to do it with one scope manufacturer. It has to be applicable to everyone, like the program that Medtronic has developed. And then we need to differentiate beyond it. And this, I think, will be the most challenging, differentiating a lymphoma from a neuroendocrine tumor and so on. We need correlation, but I think it's going to take a very long time. And this is a good study from China where they looked at how do we perform compared to a trained model. And this was just a normal anatomy asking us to perform an EUS and having EUS AI trained very well, and they looked for identification and miss rates and so on. And what they found is that it was a randomized trial, and what they found is that the AI group performed much better than the control group. Because the model is very trained, it will tell you when you have not done a complete examination and when your examination is incomplete. And when you do obviously a structured model, your diagnosis is better. And obviously the operating time will be more like what we will do with AI in colonoscopy. So this is an important study only looking at thoroughness of examination, in other words, quality control. So therefore, AI has the potential to improve the quality of exam. Now what we need to do is to bring everything together. So this is one problem, right? We can't, we need to get what they did in China. It's very important. We need to take our data on what we do with differentiation of different pancreatic lesions. We need to put them all together, and then we need to develop phase one, hopefully with one scope, make it applicable to everyone. I think it's going to be harnessed about 5 to 10 years because endoscopy is quite simple. We look at it and we know what we are looking at. EUS interpretation has got so many difference. Even pancreatic cysts, all of us can have different interpretations. So it's going to take a very, very long time to conquer EUS and AI. But I think I wanted to thank Medtronic because this was a difficult symposium for anybody to sponsor. It has to come from the goodness of your heart, and each company had one. And I told them, can you please do EUS, because I would think the audience would be in my shoes with limited knowledge on where this is going. And finally, I think we will move to the next sessions of colonoscopic examinations with the live demonstrations.